Hey there, my name's Peter.
And I'm Joe.
And the reason we're here is to teach you how to put a Minnesota tube in. So the purpose of this is we'll give you a quick rundown on how it works, how to put it in, and when you should put it in.
Alright, so if you're looking for a Minnesota tube, you'll have a box like this. And this is what it looks like inside.
Alright, so why would we need a Minnesota tube? The reason you would use one of these is if you have an upper GI bleeder, a variceal bleeder, and you need to tamponade the bleeding as soon as you can. Usually GI will do a scope and they'll say, oh well, you know, we saw the bleeding but we couldn't stop it. They might have to go to surgery. To temporize them, you would put this tube in. Now how would you put this in? There's two ways. Believe it or not, you can put this through the nose and that's the recommended way, or you can put it in the mouth. Hopefully these patients are intubated so you can put it next to the ET tube. There's two different parts to this tube. There's the distal portion, which is the gastric bubble, and then there's the proximal portion, and this is the esophageal portion of it. What you want to do is you want to inflate this gastric bubble first while it's all the way in the stomach. The instructions for this specific tube say to inflate this to 250 cc's. Then you'll pull it back. Hopefully you're still within the cardia of the stomach and not going into the esophagus. If you're pulling up traction and still moving up, you want to inflate this to up to 450 cc's, and it seems like a lot, and we'll show you what it looks like. As far as this esophageal portion goes, you want to inflate this so it has about 100 centimeters of mercury pushing out against, what is 100 centimeters? 100 millimeters of mercury pushing out against the esophagus, and the way to assess that is with a manometer. Joe and I will put this together and show you how to do it really fast, okay?
You'll need some other things besides what comes in the box, because the box basically just comes with a tube. So if you are looking for some things, all you'll need is what I have down here in front of us. So you need a 3-way stopcock, 2 clamps, doesn't really matter what kind they are, and then a Luer-locked 60 cc syringe, preferably. So if you're looking at the ports on the Minnesota tube itself, they're labeled usually, and you can actually see, like this one here says esophagus balloon, and the one on this side is stomach balloon, and then there's a port for aspiration, gastric, and esophageal. So you can look for the labels, and they also come with these plastic pegs in them. There's 2 for each of the balloon ports. And what you want to do is you want to remove one of them from each of the balloon ports. So you just take these out, just pop them out.
So Joe's going to start inflating the gastric portion of the Minnesota tube.
Yep.
And we'll go up to how many cc's?
We'll do 200.
All right.
Sure.
So he's got the 3-way stopper on the syringe.
Yep.
He's finding the port to inflate the gastric portion of this Minnesota tube.
Yep. And you just slide it on there, and it'll go on fairly easily. And then I'll just fill it up with some air.
Now it's important that you count, or at least calculate how much you put in.
Yep. So I got 60 in there. I'll blow it up.
Whoops.
And you can just, if you have the stopcock, it helps that you can just kind of go you can go a little quicker. That's 180. And we'll put in another 20 or so. And if you look at the balloon now, this will give you an idea of the size that'll be in the stomach. And if you actually have someone listen over the stomach while you fill this up, they'll actually be able to hear this while you're filling it up, to give you an idea of where you are in the GI system. So that'll give you a better idea of what it'll look like when you want to start pulling it back and put some tension on it.
You've got to take a syringe with the tip exactly like this, and you can put it into the gastric aspiration area or the esophageal aspiration port. When you place the tube, put the tube all the way down and try to aspirate from the gastric portion first to see if you get blood or gastric contents. If you do, you know it's appropriately placed, and you can actually hook this port up to suction. Now the most important part of this Minnesota tube is not actually sucking out the blood, it's actually stopping the bleeding. So make sure you inflate the 2 areas as Joe has mentioned and displayed prior.
So this is about the size that it'll be when you actually have 400 cc's in it. So
don't be alarmed by how large it is, and don't let GI tell you you can't inflate it more than 100 cc's, but because you can.
Because you want something to actually tampen out those vessels off. So you want to have a good, you want a lot of air in this balloon. Because when you actually pull on it, it'll sit against the stomach.
Right at the gastroesophageal border.
Once you've filled your gastric balloon, you're going to want to clamp it off. And the easiest way is just to use a clamp.
The reason of that is so the air does not seep out.
Yep. I'll switch to the esophageal balloon here. Now normally you just filling the gastric balloon itself should hopefully tamponade off most of the bleeds. But if you need to fill the esophageal balloon as well, try and have a manometer set up. And you can do that using this extra port in the setup in the ED. Alright. And then just filling this up just the same way with the stopcock and the syringe. And just to give you an idea, this is about 100 cc's right now, and that's the whole setup right there. And then if you had this, you would just clamp it off as well. And then you could get rid of your syringe, and it's done. So that's the inflation portion of it.
Okay, and how do we attach it? Or what do we do with it?
So if you want to attach it, there's a few ways to secure it. One is the old way where they do a football helmet. They just put it on the patient, but you don't have good access to their face, so a lot of people don't like that one. Also, you can attach, you could use like a tourniquet and tie that to a weight, like an orthopedics weight, and then set up just a pulley system to actually pull some tension on it. So those are kind of the two ways that are usually used.
And orthopedic weights they'd use between 5 and 10 pounds, ideally, and it looks really barbaric. But this is kind of an old school way to stop GI bleeding, and you only do this kind of as a last resort, and hopefully it works.